Hey everyone, I wanted to touch base and do a quick review. I know we've only had a few days to cover this stuff on Unit 10. I'm going to try to do it all at once, and we are going to skip some of the videos and things that I hope you would already know by now. Terminology, anger is that emotional response. It is normal. We're supposed to be angry. However, aggression is when there is an attack. Physical, verbal, we're yelling, we're screaming, we're punching someone, we're hitting the wall. Violence tends to be intentional. I am going to think and plan for something to happen that where someone is going to get hurt. One of the most important things when we talk about anger, aggression, violence is we want to prevent it. We need to do that primary prevention, education to kids, decreasing risk factors, get involved super early because once someone is already angry, once someone is becoming aggressive, it is much harder to stop. So we're not going to watch this video. However, we can kind of see rates of violence has doubled in psychiatric facilities. We see higher rates of violence and aggression. We watched all these little videos in those who work in healthcare. We see greater rates of violence and aggression, specifically in those who work in mental health settings, elderly, memory care, Alzheimer's, dementia type settings, and those who work in the emergency room. And I know that are things that when we talk in class, y'all see it too. So risk factors, some are genetics. We do have some people who are more biologically predisposed to others to become easily frustrated. We talked a lot last exam about our impulse control disorders, intermittent explosive disorder being one. We do have some neurological conditions, Alzheimer's, that's sundowners, if we have any brain tumor or brain injuries when it can come into place, maybe even epilepsy. Um, we do see dysregulation in the limbic system. Our amygdala is what makes us angry. Men who have smaller amygdalas tend to have higher levels of aggression. We see lower levels of or higher levels of testosterone, lower resting heart rates, all sorts of different changes in the brain that happens, changes to the prefrontal cortex. Serotonin can stimulate aggressive behavior. GABA reduces aggressiveness. Our behavioral theories tends to be that this is a learned behavior to a stimulus. We kind of learn that something is a threat and we learn how to react to it. Social learning, especially children learn aggression by observing others from video games, from TVs, from their friends, from their family members. Especially if we tend to see aggressive behavior being rewarded, that is where we're going to learn it. So when we're assessing aggression, we do have to look at that history. If someone has a history of aggression, I want to kind of have like my spidey senses going and be paying attention for what is happening. Kind of just like we're going to assess pain, I also want to know what makes that violence, anger, aggression worse or better. Do I have a patient with a history of abuse and they were abused by a certain individual, and anyone who reminds them of it triggers it and makes them more angry? Um, we want to kind of take those steps, that continual assessment of recognizing, is there increased demands, irritability, frowning, redness of the face, like twisting, clenching of the fist, hands like punching. Look for any of those changes. In our environment too, it is very important to recognize what is going on. We again are in mental health, and a lot of this does tend to lean towards mental health. But if I have overcrowding in that my unit is full, and I have new staff and I have a bunch of new admissions who are coming in, and one person starts going off, then someone else starts to go off. Sometimes it is that environment that can increase. If we can't set limits, if Jim always lets the patients get away with stuff and I come in and I'm following the rules and I'm like, no, you can't have an extra phone call, that patient's going to be upset. Well, because Jim let me do it. And we always have to be aware of what we are feeling, our strengths, our vulnerabilities. Do we need to tap out? Am I so tired and frustrated and everyone has just been on my nerves today and my tone of voice is changing? What is my nonverbal showing? Because oftentimes we can trigger our own patients. So implementation, we do have to look before there's any sign of escalation. That is when we want to intervene. As always, one of the first things we want to do is develop that therapeutic relationship, right? Have numerous tiny little conversations, non-threatening, talk about the weather, talk about what interests the patients. just to have that relationship. Look at our interactions with the patient. Let the patient know we're concerned about them. And then a lot of that staff safety that we've seen all corner. Stay far away, have that calm demeanor, make sure both us and the patient have that escape route. We don't ever want to block the door because then our patient feels trapped. Slowly, short sentences, low and calmed voice, model that appropriate behavior, open-ended questions, look for the patient's opinion, um, watch the environment. Maybe we just need to get them somewhere where they can kind of calm down. What are we wearing? Is there anything that is potentially a weapon within the environment? Why we don't have a lot of patients on psych units with canes or crutches? We have a lot of wheelchairs because it's harder to throw a wheelchair. So in that de-escalation technique, make sure we again are aware about our own response to anger. And then we want to model. We want to keep that self-esteem and dignity. We want to honestly sometimes get everyone else out of the way. Clear, simple directives. Um, do they need a snack? Like, do they just need a break? Are they overwhelmed? Medications are great choices. Antipsychotics and anti-anxiety meds are going to be the two we tend to go to first. Sometimes even like a Vistaril if we're getting there early, not just like a benzo. Um, in that moment, if someone is aggressive, we can't identify coping skills. That's that primary prevention. We have wanted, hopefully, have already talked to you about your coping mechanisms. What helps calm this person down before you escalated? I'm not going to approach an angry patient alone. I'm going to bring one of my friends with me. And it gets hard because we don't ever want to bring all of our friends. So sometimes what you see, and we can skip over to this next slide. I know there's a lot here when it talks about mechanical restraints and seclusions. Sometimes we have what's called a show of support, where I'm going to call almost like a code and we're all going to go in there. Maybe I'll have security involved. But if we have a patient and they've already been tense and upset and I bring 20 friends with me, that is really going to tend to set them off. If I bring one friend with me or I have one friend who was watching out for me from the distance, because our goal is to avoid these restraints and seclusions. These are last resorts. We are only going to do this if our patient is at risk of harm to self or others. So if you're punching a wall, I'm going to let you punch the wall. If you start punching that window, or if all of a sudden you start punching someone else. So we do need to make sure we have a doctor's order, but again, this is our psychiatric code. I am not waiting for you to start beating someone up and then, hey, you've been punching, Jill for 10 minutes. The minute that our patient punches someone, and that is just my example, the patient comes up and sucker punches the nurse from behind, we can call that code and put the patient in restraints or seclusions within what we are allowed to do within our facility policies. It's going to be different depending on your facilities, what method of restraint or seclusion you're using. Do you have a restraint chair? Are you doing a mechanical restraint? Are you doing just a physical restraint where we're holding the patient? How old the patient is? So many different things come into play. But just like we talked about, if I have a patient who stops breathing, I'm not calling the doctor to ask permission to do CPR. So nurse gets sucker punched from behind from a patient, we put that patient in restraint or in seclusion. We have 1 hour to get that doctor's order. If this patient was escalating and we saw that escalation happen, we need to document and we need to have tried some least restrictive measures. We did some one-on-one, we provided patient with coping skills, whatever it is we did. Once that patient is in restraint or seclusion, they are now on a one-to-one. Every 15 minutes as a nurse, we should be checking on the patient. If it is a mechanical, so that tie-down type restraint, we're assessing vital signs, reanimation, blood flow every 15 minutes. We do need to provide nutrition, hydration, chances for the bathroom, but that's like every 2 hours. It is not an every 15-minute thing. If I have an adult in the state of Texas, I can legally put him in seclusion for 4 hours. However, that is 4 hours if they're still arguing and fighting and being aggressive. Once my patient has calmed, we need to look at how we release them. We do want to think about that too. We're not using any restraints at the neck. We have to realize strains can re-traumatize our patients. I will never restrain in a supine position. I will honestly never even restrain in the prone. You generally want on the side. A lot of places are moving to restraint chairs. 4 side rails up is restraints, a whole bunch of different things. That B52 is often what we call our chemical cocktail. It's also the name of a plane. 50 of Benadryl, 5 of Haldol, and 2 of Ativan that we do give to these patients. Honestly, I've seen Thorazine, I've seen 20 of Haldol, 4 of Ativan, any mix. Just like our physical restraints cannot be in a standing order, and we cannot have a standing order for seclusion, we cannot have a standing order for these medications for agitation. They need to be a one-time order, and we need to be calling the doctor to get that order. So we watched this video in class. We're going to skip it though on de-escalation. We've already talked about a lot of these considerations for staff safety. We went through these in class. Should I apply a restraint or not? And y'all usually do pretty good just because you have that experience. So we are moving on to Unit 10, our second part, which is going to cover sexual assault. So when we look at sexual assault and sexual violence, these are very broad terms that encompasses a whole bunch of things. Unwanted sexual advances, sexual harassment, stranger rape, marital rape, date rape, drug-facilitated rape, incest, human sex trafficking, genital mutilation, are all things that could fall under it. We have 2, in theory, types of restraints, completed and attempted rape. So completed is when there was penetration. And that penetration can be of the vagina, the anus, or even the oral cavity. It could be by a body part or it could be by an object. Attempted rape is when something interfered. The rape was going to happen and then someone walked in the room. We have tons of different scenarios we can go through when it comes to offender and victim. However, the 2 that we do have to think about is spousal rape and acquaintance rape. Oftentimes we know this individual. You're out on a date. It's your friend. It's your husband. And I will use a lot of pronouns in this lecture where the offender is male and the victim is female. Statistically, it is more likely to be female who is the victim. But again, we have to remember males can be sexually assaulted and males can be raped. It happens more so than we probably think because males are less likely to report. So when considering date rapes, we do have date rape drugs, and when combined with alcohol, they tend to have this amnesic effect. The patient is unable to fight off the witness. They may go unconscious. Oftentimes, because we see this patient come in and we think they're just drunk, we get that kind of negative mindset. We don't always screen the victim and do that tox screen to see if there is some type of drug in their system. So one of the most important things to think of is if we have someone and they come in and they're intoxicated and it looks like a sexual assault has occurred, treat it like a rape. Do get the rape kit done, do a tox screen. The fact that these medications, and they're meds, these drugs are causing the victim to develop amnesia, the fact makes them an unreliable witness. So if you don't remember what happened, it's hard for you to testify. So every 73 seconds, an American is sexually assaulted. Almost half of when we look at female victims, it's an acquaintance who is the one who has been raping them. So we've talked about acute stress disorder before. This is not PTSD. This is in that first 30 days. Remember, PTSD is going to be post 30 days. These are the symptoms that come in, the symptoms that we do tend to see. They do mirror our PTSD symptoms. So dissociative symptoms, that depersonalization, that out-of-body experience, the derealization, I'm walking through clouds, flashbacks, nightmares. When we talk about intrusive symptoms, it could be nightmares. Avoidance, we're not going near people, we're not going near places or things that remind us of the situation. We do have a specialized nurse called the SAE nurse, a sexual assault nurse examiner. And this is a nurse who has you generally have your BSN, you have experience in a more medically concentrated field. You very much need your safety skills, your examination skills to be very good. And you go through additional training, preceptorship hours with an emphasis on how to do this exam and how to appropriately collect the evidence. This is a nurse who is doing that rape kit. We are supporting, we're providing that language. We're not going to leave this patient alone. We're doing that full head to toe assessment and we're collecting the evidence for if this patient wants to go to trial. One of the biggest things is that trauma-informed care, we do not want to re-victimize this patient. So a few things in the nursing assessment. Even before we assess, we have to develop a relationship with this patient. We establish a relationship, we and then we're going to start to collect the evidence. Um, you can't just dive into this. Um, we want to stay with the patient. We want to support them. After we have supported the patient, we've developed that relationship, then we're going to look at all of these different things. We do have a physical exam, but we also have to look at their anxiety. What coping mechanisms? Do they have a support system? These patients are oftentimes going home right after this. Um, and that self-assessment is also really important. It's always important in psych, but especially here. Um, if this patient's been there before, right? They're unhoused, they have a history of drug abuse, they come in every few weeks and they've been sexually assaulted. Um, that might change our opinion on how we interact with this patient, but it should not change our opinion. Um, so we do have to think about that. So we're going to do a very detailed physical examination to include a genital exam. So we've developed that therapeutic relationship. We started kind of with some of those suicide, anxiety type things to see how our patient is doing. We are about to start that head to toe. Before we start the head to toe, we have to communicate with the patient everything we are going to do. The patient just, if we talk about rape, they had their autonomy taken from them. They were not able to say no. So we do need to say, hey, this is what this exam entails. You know, if they have a bite mark on their arm and we want to take a picture of it, I'm going to ask permission before I take that picture. Is it all right if I take photographs? If the patient says no, we do not try to explain to them why this is important. We just say, okay, and we move on. Sometimes, and we as nurses know, hey, we need this stuff, we need the pictures, we need the evidence in case you want to go to court. However, someone just coerced this patient, so we very much don't want to re-coerce them. If they say no, they say no. This again is our rape kit. It is what it looks like. It is very detailed and invasive. Why we want to explain what is happening ahead of time. Rape trauma syndrome is a specific nursing diagnosis that looks at the sustained and maladaptive response when we see that forced violent sexual penetration. Um, Nurses have noticed patients have very similar characteristics. Again, nursing considerations, we want to watch what is being said. If we have someone comes in and they were out with their friends, they were super intoxicated, and then they got raped, we don't want to be talking in that ER, right? Things can be heard and be like, oh my God, but she was so drunk. So we do have to look at the small things that are said in the area. We have to support the patient. We want to look at support systems. Again, this patient is probably not getting admitted to a psych unit unless they're also having thoughts of suicide, harm to self or others. We want to refer this patient for therapy, individual therapy, group therapy, like a support group is wonderful. Um, we look at those PTSD type symptoms and we can see that our patient is doing better when we're seeing return to pre-rape functioning. They're sleeping without as many nightmares. They're eating okay. They're calmed. They're not as fearful. They're talking to family members and friends. They have positive thoughts about themselves. We're not having the somatic reactions. We have some videos if y'all are interested, and I know just because we're moving, we're going to older adult. Child, older partner, older adult, and intimate partner violence. So abuse, neglect, exploitation. So we have a few different types of abuse. Most of these are ones you're pretty clear about. Physical, sexual abuse are ones y'all pretty know. Emotional abuse, you're so stupid. I should have had an abortion. I wish I would have never had you. If we're talking about like kids, if we're talking about an elderly adult, emotional abuse could be, Grandma, if you don't stop it, we're going to go put you in a nursing home and never come visit you. That could be emotional abuse. Neglect is one we often tend to forget about as a type of abuse. It's the failure to provide for physical, emotional, educational, medical needs, not sending your kid to school, not taking them to the doctor. They don't brush their teeth and they have abscesses. And we're like, well, it is what it is. Um, Neglect is one we shouldn't forget about, though, because it is the one we see most common. Neglect is the most common type of family violence. Exploitation and economic involves controlling finances, not letting someone have a job, not letting someone keep their money. Digital abuse is a new one, and it's using technology. You're going to put trackers on someone. You're going to track their car. You're going to track their phone. You're going to not let them have social media or talk to anyone. So, child abuse is anything to a child. So, those under the age of 18. We do have some risk factors, those younger than 4, if this child is perceived as being different. Autism, ADHD, Down syndrome, even chronic medical conditions. If you don't live with your parent, if you're a result of an unwanted pregnancy, if something keeps the parent and child from bonding, it could be again, maybe the child has autism and they're not forming that bond, or maybe the parent has a history of substance abuse, or the parent has a history of depression where they are not bonding. If we have neglect, we are likely to have physical abuse. If we have physical abuse, we're likely to have emotional abuse. There's often just not one type of abuse. If we look at that abusive parent, they themselves have a history of abuse, that behavioral theory. Low self-esteem. Drug and alcohol is a huge red flag for any type of abuse. It lowers our inhibitions. It tends to make us impulsive. If there's social isolation, unrealistic expectations, if we expect our 2-year-old to be potty trained. If we get frustrated easily, that poor impulse control we've talked about before. Intimate partner violence, we do have quite a bit. So this can be a spouse, a boyfriend, girlfriend, dating, any sexual partner. Again, I've been using pronouns because 4 out of 5 victims are women, but that does not mean that men are not also exposed to risks of intimate partner violence. A lot of our risk factors do point to males who have that belief in male dominance, a lot of jealousies. Again, we see that substance abuse come in, and also pregnancy. In pregnancy, the woman tends to make a move for independence. And when you make that move for independence, we see that increase in violence. We have a few different stages in the cycle of violence. So that tension building stage is a lot of minor incidents, maybe some verbal abuse, maybe some pushing. The victim will oftentimes ignore what is happening because they're afraid of escalation. Abusers are like, this behavior is acceptable, it's appropriate. However, as the tension builds, especially that victim, they want to try to reduce it. The abuser may be drinking, and the victim may just be like, oh, it was just tiny, it was just tiny, it was just tiny. The acute battering, serious battering stage is when that tension peak and there's some type of event that triggers it. There are some experts who believe that the victim provokes that incident because that tension in that tension building stage got too great. They feel like they're walking on eggshells. If I go and get this over with, he'll beat me, and then we go on to that honeymoon stage. And I'm not saying that person wants to be abused, but they're so tired of walking on eggshells. And they know in that honeymoon stage, that abuser is going to demonstrate kindness. They're going to be loving. They're going to be remorseful and apologetic. I promise I will never do it again. If the person in the tension or the serious battering stage was making plans to leave, those might be abandoned once we get to that honeymoon stage because he really loves me. This cycle does tend to repeat itself over and over and over again. So a lot of our nursing considerations for these patients have to do with when we talk about safety. We don't want to have negative feelings and be judgmental. Well, she's asking for it. Why hasn't she left? We might be afraid. We might be confused. We might feel helpless. There's often a blame the victim mentality. We need to make sure we're assessing these patients appropriately. If we have a patient, and we talked about this in class, everyone always asks me, I take my kid to the ER, and they always ask my kid, do you feel safe at home while I'm sitting next to him? Statistically, as a biological mother, I am more likely to be his abuser if there was abuse going on. So we don't always want to ask those questions while the partner is there. We want to make sure we're asking them separately. And sometimes they might say, no, I'm not getting abused, because maybe it's not physical abuse. Maybe it's emotional. Maybe it's economical. So do you have time for yourself? Do you have access to financial resources? If we're talking about kids, how do you and your partner decide on punishments for the children? There are other questions we can ask. Do you have time for yourself? Education and resources, we very much want to talk to this individual about how to plan to leave. Because we see that increase in violence when someone is making a move to independence. Hey, um, make sure you have your money set aside. Find your driver's license, find your social security cards. If you have special medications, if you have diabetes, right, pack your insulin. Don't worry about your toothbrush, don't worry about your makeup, but just what you need to go, and also where to go. Individuals may not want to leave, right? Maslow's. If I have nowhere to live, I'm not going to leave. So educating them about locations of local shelters. Older adult abuse is a serious concern, and oftentimes what we see is financial abuse. Um, Grandma has no need for her money, so we're going to spend grandma's money. Sometimes it's not even grandma, sometimes it's the caregiver. We might have a CNA or a home health nurse who's going into the patient and stealing from them. Coercion is also a real thing. Someone this quarter brought up in one of our classes about someone who they had an elderly patient and fell in love with one of like the CNAs, and the CNA married this elderly patient, huge age difference, and this person died shortly after. And they were able to get all of this individual's money and assets. Our risk factors for older adult abuse. If they have poor mental or physical health, especially if we're talking about Alzheimer's. If they are dependent, that single caregiver, dependent on their perpetrator, especially if it's one of, let's say, like a child. Grandma is sick, she has Alzheimer's, she's dependent on home, and it's her daughter who is taking care of her. And that daughter lives at home with her and is her sole caregiver. That caregiver role strain comes into play. Um, if we have a parent who abused their children, elderly father, especially cared for by a daughter he abused as a child, an elderly woman who is being cared for by her husband who has abused her in the past. Uh, those are big risk factors when we look at older adult abuse. In general, this little infographic is about pediatric abuse, torso, ears, neck, especially in children younger than 4. Those physical signs. I do not expect a 6-month-old who's not crawling to have bruises. So if we do see bruises, especially in different stages of healing, internal injuries, miscarriage related to an injury, we do have to look further. We want to allow the individual to tell us their story. A lot of those open-ended questions to try to kind of carry on the conversation, but let them use their own words. We do have to look for suicide and homicide risk in everyone involved. If you were just abused, you're more likely for suicide. Homicide, honestly, from the abuser. We don't want to leave that victim alone in the emergency room. Drug and alcohol abuse by everyone. If the perpetrator has a history of drug and alcohol abuse, right, we're more likely to see that abuse. But also, do we have someone who is abusing their child and they have now gotten their child addicted to drugs? That is a thing. So we do have to look at a history of sexual abuse, family violence, drug use by everyone involved. Um, we want to look at how we're talking. We want to talk to the victim alone. Um, we don't want to have like a group of people in the room. We don't want to have someone who may be the perpetrator in the room. Um, we want to look at support systems, ask all of those questions. Sit near the patient, talk about how they solve agreements. We never want to assume a person's sexual orientation. And those records are extremely important in case anyone ever wants to press charges about what is happening. So if we suspect abuse, we have to report it. We are legally mandated as nurses, especially we'll look at the state of Texas in a second, to report suspected or actual cases of child and vulnerable adult abuse. So 22-year-old female getting abused, she is in her right state of mind, no psychiatric or mental conditions. We cannot report that unless she wants us to. If she's like, I want to call the police, I want to report this, then definitely changes the scenario. But if she's like, no, I'm going to go home, he doesn't mean it, we have to support her. If I have an 87-year-old with Alzheimer's, that is reportable. If I have a 25-year-old who's been in a coma for the last 4 years and there's signs of sexual or physical abuse, that has to be reported. And then any child. We cannot be judgmental. We have to talk about that education, that safety plan, how to plan to leave. Referral numbers, maybe even help the patient make a phone call if they want. Specific populations we do need to pay attention to is new parents, right? If your baby's crying, it can be hard. Um, Letting them know it's okay to put the baby down and walk away and let the baby cry. Teenage parents, their children themselves, and they may need assistance on how to provide care and how to attach to their child. If we have a parent with a cognitive deficits themselves, they may not recognize what is going on. And then again, if we have someone who has a history of abuse, they're more likely to abuse others. So specific, this is some of the laws in Texas. We have to report. We have 48 hours where you can get fined or jail time. Primary prevention of abuse we've talked about before is anything we're doing to modify those risk factors, to get rid of them. So if we do drug and alcohol prevention, that can decrease the risk of abuse and violence. Any type of education, coping mechanisms, stress management, social support, all of those come into play. Secondary prevention is screening programs. So when I go to the ER with my kid and they're like, do you feel safe at home? Or when I go to the doctor and the doctor asks me, do I feel safe at home? That is a secondary screening. We want to try to identify the violence early. Tertiary prevention, the abuse has already happened. You go into the ER because you were raped and assaulted. You go into the ER with a few broken bones because your husband beat you. At that point in time, it's that support for survivors and families. What can we do to minimize the long-term effects? Maybe you have that acute stress disorder. How do I keep it from becoming PTSD? Support groups, again, we have a few different options. Support groups are great, that universality. I'm not alone. Other people have gone through similar circumstances and they have been able to get through it. Individual, family, and group therapy. Again, it talks about victim and abuser. Depending on the situation, it's therapy for the victim and then a separate therapy for the abuser. There may be times where we are doing it together as a group. However, it's going to be on a case-by-case situation. We have a whole bunch of resources. We don't have very much in the slides about it, but human trafficking is a very big thing. Y'all have all been working as nurses, and I know while you're in school, you don't need CEUs. However, in the state of Texas, whenever you're renewing your nursing license, you should be doing CEUs on human trafficking. As nurses, we are the largest component of the healthcare system. There are more nurses than any other healthcare profession, so we are more likely to be the ones seeing those human trafficking victims. And we should be able to recognize and spot it. Most individuals who are trafficked, they wind up coming to America. So you get taken from other countries to America. So we do definitely have to watch out for it. If y'all have any questions, please let me know. Otherwise, I hope y'all have a good day.